Dr. Dodick, hi, and thank you so much for joining me here at Faces of Digital Health for a discussion on brain health, a little bit on dementia and recent findings in Alzheimer's disease treatments, but also the role of digital health and healthcare digitalization in addressing brain health issues. So thank you for joining me.
Oh, it's my pleasure. Thank you for having me.
Let's start with a bit of a warm-up. As I mentioned, we're going to talk about brain health, and one of the core hopes that we have in, healthy aging and aging well is to stay fit as long as possible, and that's from the physical and mental perspective. So if someone in their 30s came to you and said, I'm afraid I'm going to get Alzheimer's disease or that my cognitive abilities are going to decline, what would you tell them?
Well, I would first dive a little bit deeper on why it is that they think that. Why are they concerned? Is it based on a family history? Is it based on prior injuries? Is it based on other conditions they have? So I'd go deep on why they have that concern. And then I would talk about the landscape as it pertains to brain health, what one can do to actually optimize one's brain health, one's cognitive longevity, and everything we can do now to mitigate the onset of dementia and Alzheimer's disease. I would tell them that, a group of experts got together and published a consensus paper and said that up to 45% of dementia can be prevented. Now people are sort of talking that maybe if one looks at other risk factors, maybe up to 73% of dementia can be prevented. And when you consider that in 2025, and also consider the fact that the pace and the advancements that are being made in medical knowledge is doubling every 2.5 months. So when you think about what's here now and what could be here in the next year and what could be here 2 years, and for that 30-year-old, what's going to be available when they're 40, I think Alzheimer's disease and dementia, I truly believe that there is a future where this will be a thing of the past. So I would reassure that 30-year-old that they really, there's so much we can do now. It would require some evaluation of he or she to determine what their cognitive health is now, what their risk factors are, so that we can biologically optimize their health to mitigate and prevent any onset of not just dementia or Alzheimer's disease, but also just of cognitive decline. Because I think we treat cognitive decline as an inevitable consequence of age. In this country and really around the world, we even have memes around it, like senior moments, for example. And I think that's an utter lack of imagination and an underestimation of what we can do to mitigate cognitive decline over age.
I'm happy to hear your optimism around, the treatment of dementia and Alzheimer's disease, especially since what we've managed to do so far is slow down the progression of cognitive decline, but not really treat the disease. But before we go into that, the 45% that can be prevented, can you elaborate that a little bit? So how do we actually do that? What's the basic hygiene or suggested measures for keeping well, apart from sleeping enough? Because I think a lot of awareness has been done in the last few years in making sure that people understand that sleep is not a wasted time, but it's an important time for a brain regeneration.
Great question. So the Lancet Commission that was published a few years ago, which estimated that 45% of dementia can be preventable, was based on the presence of about 14 different modifiable risk factors. Half of those risk factors were what we consider to be cardiovascular risk factors. So glucose or blood sugar homeostasis, blood pressure, LDL, and other bad cholesterols, if you will, obesity, right? Increased body mass index. So some of them were cardiovascular risk factors, and then others were not. They were hearing loss, vision loss, social connectivity, and so on. So looking at those 14 modifiable risk factors, if one modified those at an early age, or even at a middle age, or even at an older age, you reduce the risk of dementia. I'll put this in numbers. So hearing loss, for example, hearing loss turns out to be, our brain thrives on sensory information coming into it from our nose, from our eyes, from our ears, from touch. Hearing loss, if you corrected someone's hearing loss over the course of about 3 years, you reduce their risk of cognitive decline and dementia by almost 50%. So when you put these all together, if you modified those risk factors, if you knew your numbers, blood pressure, blood sugar, LDL, and you optimize those, you substantially reduce the risk of dementia. And by the way, the 45% that's now being estimated to be higher than that is based on the fact that some of the modifiable risk factors that we know are important, you just mentioned one, sleep, and another one might be microbiome, another one might be vaccines, another one might be hormone replacement therapy, weren't even considered or integrated into that calculation. So when you consider all that we know now, it's at least 45%.
Mm. I always have a bit of a challenge with the statistics because, we figure something out on the population level, and then that's very difficult to translate on the individual level. So, for example, I'm going to give a very, maybe not the best example, but for example, we know how bad smoking and alcohol are for health on so many levels.
Yes.
But there's many people that I guess would smoke and would live a long time, and they would try to dispute the negativity of poor behavior or lifestyle choices. So how can what can each individual take from those 45%? Like, what do you usually advise people to do for their brain health, for example?
So I'm really glad that you raised that, a very important issue. And that is that in medicine, we often apply population statistics and mean averages from clinical trials to the individual patient sitting in front of us. Now, because that's the best we can do. Actually, it's not the best we can do. It's the best we can do in clinical practice today, general clinical practice. But in actual fact, if we measured someone's whole genome, right? And we knew what their gene expression profiles were. And we looked at, and now, I think a very important paper was published a couple of months ago that looked at 3,000 different proteins and measured the age of each individual organ. So imagine if we could drill down on a personal level and know what genes are being expressed, what their inflammation score is, and what their organ age is, because these 3,000 proteins measured the age of 11 different organs. And some people had rapidly accelerating brain age. Some people had extremely youthful brain age. It turns out, since we're talking about brain health here, that brain age is really the gatekeeper for longevity. What do I mean by that? For those people who were extreme agers, if you will, on the brain age side, they were 12 times more likely to develop dementia and 182% more likely to die within 15 years. So brain health really is the unlock for mortality, and it's highly predictive of the onset or the risk of Alzheimer's disease. So here's an example of where we can measure with incredible precision at a molecular level what someone's risk actually is. So if you ask me the question, but doctor, I really enjoy my glass of wine with dinner, right? If you had 2 copies of what we call ApoE4, which is one of the highest genetic risk markers for Alzheimer's disease, and you had a lot of visceral fat, and you had some insulin resistance, and you had blood pressure that's not being well controlled, and you also enjoyed a smoke with that glass of wine, I would tell you, don't go there. And if I was able to measure if you were one of these extreme or moderately severe brain agers, I would say no amount of alcohol is safe for your brain. On the other hand, if all of those things were absent, I would say have a glass of wine with dinner, right? So we have, and you know, as well as I, and everyone knows that we have these guidelines for alcohol consumption. I mean, we're getting into alcohol here since you mentioned alcohol, where men can have 2 drinks per day and women can have 1 drink per day. There are women and men who should have 0 drinks per day. And there are others like these centenarians that we've seen so often. What's your key to longevity? And they say, well, it's my highball every night. I love my highball, right? And so that's where people say, well, why can't I drink alcohol as well? Because I've seen these people live to 105. So why can't I drink it? It's all about understanding one's molecular and biological and genetic risk. So that's how I would answer that question.
Yeah, it's when it comes to risks, it's becoming increasingly individual because we know more and more. We can also measure and predict more and more and just tailor treatments or recommendations per individual, their lifestyle and their genetic blueprint. But when it comes to public policy, we obviously are trying to find something that is possible to generalize and recommend on a wider level. What I'm getting to is the question of, in the last 2 years, the guidelines or just the general reporting around alcohol has changed significantly. So we went from saying that, maybe a few drinks are okay, to research showing that no amount of alcohol is really good for your brain, and also other aspects of chronic conditions, inflammation, etc., etc. So my question here is, how come, based on all the knowledge that is coming out, there's not more outcry or professional recommendations to regulate alcohol differently? Because there's a lot of change happening, around psychedelics, around cannabis, but we are not even discussing changing restrictions around alcohol, despite the findings about how harmful it can be.
I think these things take time. So, 50 years ago, we were in the same situation with tobacco, right? And now everyone knows that you shouldn't smoke. And in fact, it's been banned from public places and restaurants. And now I remember it wasn't just 15 years ago where you could go outside and have a smoke. Whether you, even at hospitals, if you worked in a hospital, you could have a smoke outside the door. Now you can't be within 150 or 200 feet with a cigarette. And all of those things happen gradually over time. I think alcohol is going to be the new tobacco. And I think you're going to see changes already. We've seen that the Surgeon General in the United States has come out and they're going to be putting warning labels on alcohol like other countries have done. Just talking about the health risks, not just to pregnant mothers, but also just to the general population, that this is a carcinogen. World Health Organization considers alcohol a carcinogen. So I think you're going to see these things evolve over time. But like everything else, even in medicine, it takes 15 to 20 years to translate some of the advances that are being made today into practice. And that's partly why I am where I am right now, because the ability to translate science into medicine real time allows us to biologically optimize the health and understand the risk profile and create an avatar, if you will, or a digital twin of what that person's risk is and how, when we apply an intervention, we modify that risk. So, but it takes time for these things to evolve. So I would say that alcohol, it's coming, and we're hearing so much more about it now than we did even 3 years ago. And it looks like younger generations are actually moving away from alcohol. Now, they may be taking up other recreational drugs, but they're moving away from alcohol because it's in the zeitgeist right now. And I really do think alcohol is probably going to be the new tobacco.
Yes, we'll have to wait years or decades to see how that's going to change, given how societally acceptable it is, and also, I guess, available. We said that we're going to talk a bit about Alzheimer's, and I'm very curious to know what we currently know about the differences and the causes of differences in the prevalence of Alzheimer's disease between men and women, and how much has that research advanced so far?
Not as fast as I would like to see it because, as you know, Alzheimer's, if you take 100 people in the United States, for example, who have Alzheimer's disease, 2/3 are women. So women are significantly more at risk. In fact, for women over the age of 45, the risk of Alzheimer's disease is approximately 20%. And so why is that? I think some research has been uncovering why potentially that is from certain gene expression profiles in the brain itself. What I mean by that is certain genes that um, are important for inflammation are turned on in the brain. Telomere length is shortened in women. Menopause plays a big role, I think. So that precipitous drop in estrogen, which can be neuroprotective, is dropped, which is why, in that organ aging study that I talked about, in the brains of women, for example, who were exposed to hormone replacement therapy, they had a significantly lower accelerated or significantly lower rate of brain aging than those who weren't.
Mm-hmm.
So I think we're beginning to understand some of the molecular underpinnings of why Alzheimer's disease is more common in women, but we've got a long way to go.
Mm.
I will say that, um, we are looking to collaborate with a group that is doing work where they take skin fibroblasts from a skin biopsy and turn them into every different type of brain cell, a neuron, an astrocyte, a microglia. And they're able to actually look at the genes that are expressed and transcribed, the RNA from those genes, the proteins from those genes, and they're actually able to identify the individual molecular or disease pathway for that person. Because if you take 10 people with Alzheimer's disease, they may have 10 different disease pathways. And then imagine if you actually took that disease pathway and matched it up with about 11,000 different drugs in the pharmacopoeia and identified the drug or the combination of drugs that actually targets that individual's disease pathway. I think that is the future of medicine. That is precision medicine at its finest. And that is here. I mean, it's not widely available, of course, and it's still part of research. But that's where I see the future going, so that it's not just, am I ApoE4 positive or negative? Do I have these other genes that modify the risk, even if I do have an ApoE4? Because we do have genes that, when expressed, can protect the brain and can mitigate the effect of an ApoE4 gene, for example. So what of those genes are being expressed in that individual? And then there are other genes that can amplify the risk of an ApoE4, for example. And so you see how complicated it is when trying to understand the individual risk and the individual molecular biology of a disease in one person compared to the other, and how that's going to lead to precision therapy. So you had 10 different, let's say, women with Alzheimer's disease or at risk for Alzheimer's disease, and you have 10 different treatments. Because right now, we have treatments that have been approved for Alzheimer's disease, and they're being given to everybody, regardless of whether or not they're likely to respond, because we know that, in the clinical trials, maybe it reduced cognitive decline by about 30%, but there were individuals who were really good responders, and there were individuals who were non-responders, but they're all lumped together. A statistical average comes out, and that's applied to you when you may be one of
Mm-hmm.
those non-responders. So I don't know if that answers your question. I'm kind of rambling here a little bit, but understanding the individual risk is going to be the key.
Mm-hmm. I'm glad you mentioned the complexity of diseases, understanding mechanisms and impact of epigenetics, genetics, genetic expression, and lack of it. And the reason I'm glad you mentioned that is because a lot of the research on Alzheimer's disease and looking for therapies on Alzheimer's disease was focused on the amyloid hypothesis and the impact of amyloid and tau proteins. There's also other proteins that have been targeted in the last few years, but the core is still basically amyloid and tau. We also have imaging techniques to detect if that's present in the brain. So can you talk a bit about the importance of early detection of Alzheimer's disease and techniques used for that? Because as I mentioned in the beginning, at the moment, we can slow down the progression of Alzheimer's disease. There's no cure for it just yet. So when somebody tells me, there's a new technique for early detection, I'm somehow not impressed because we haven't seen that much progress in having treatments. And we know that, in medicine, it's not very useful if you discover a problem if you don't really have anything to offer to the patient in terms of solutions.
Another just excellent question. So I would say that it's not so much, well, it's early detection of disease, but it's also early detection of risk. So let's say, for example, that 30-year-old came in, had a strong family history of Alzheimer's disease. We did some blood tests that showed that they were at risk. Heck, we even did a PET scan and showed that they got early deposition of amyloid, and they happened to have 2 copies of ApoE4. The way and the aggressiveness which we will modify the risk of Alzheimer's disease in that patient may be different than a 30-year-old or 40-year-old who has none of that, right? So those 14 modifiable risk factors I mentioned, I think are critical to mitigating the risk of cognitive decline in Alzheimer's disease. I will also say, to your point, that let's say 1/3 of people over the age of 75, if you did PET scans in cognitively normal people, will have amyloid in their brain, but may never develop the disease. So we don't yet know what accounts for the cognitive resilience of individuals versus other individuals, right? So to the point that you made, if you detect amyloid in the brain, let's say, if you did a PET scan on 100 people over the age of 50, and in 25 of them you found amyloid, are all 25 destined to develop Alzheimer's disease? I would say no. So you haven't detected the disease per se, you've detected the pathology or part of the pathology of the disease. And, that person now becomes a priority for other risk mitigation options. And there are a plethora of them growing and emerging beyond just lifestyle modification. You've probably seen this new study on lithium orotate. You're going to see in the next couple of months data released looking at GLP-1s, right? Semaglutides being evaluated for its role as a neuroprotective drug. So I think there's plenty that we can do. And I think I would like just also to say that it's not just about, of course, not just about amyloid and tau. One of the key factors that we underestimate is the health of what we call the microvasculature. You have about 400 to 500 miles of small blood vessels in your brain. So we are obsessed as doctors and patients about large blood vessels. We look at your carotid arteries. Everybody gets a carotid ultrasound, right? And everybody gets their heart evaluated as part of general routine practice. But we forget that if you put end to end all these small blood vessels that actually supply blood and nutrients to your brain, you could go from New York City to Raleigh, North Carolina on them. And they're the width of a hair in your head. And when they age and when they close off, that's not good for the brain. In fact, there's some evidence to suggest that when that happens, when the microcirculation starts to fail, amyloid expression and amyloid production increases. So that is why it's so important to modify these risk factors, because you would think, well, why would enhancing my insulin sensitivity and reducing my blood pressure. What do they have to do? What does that have to do with Alzheimer's disease? Because that's due to a protein that accumulates in clumps. But they're linked. They're very linked. So the health of the microvasculature, I think, is crucial. I don't know if that answers your question, but I think, there's a lot we can do today, from the organ aging clocks to I could measure a protein in your blood that has 95% sensitivity, predictive value in knowing whether there's amyloid in your brain. I don't even need to do a PET scan. I just need to do a blood test, and that's commercially available. So what's here today, and as we talked about what's going to be here next year, we will be able to, with high fidelity, determine someone's risk, not just risk, but actually timeline. So it's one thing if I said to you, you have an extremely high risk of Alzheimer's disease, but that may not be until you're 95 or 100 versus 65, right? So I think with digital technology and with the molecular testing we have available today, we will be able to determine risk, timeline, and given that technology that I talked about earlier, understanding one's gene expression profiles and their proteome and looking at the different drugs available, with high precision, be able to treat and modify the risk of that individual. So I think the future is here. A better future is coming at us fast. Now, how do we make that equitable and available to all people? That's the problem, right?
Yeah,
Major.
absolutely.
I mean, 3
When
billion,
are yeah
3
when our
billion.
liquid biopsy is going to be a standard annual checkup thing, so you'll be able to see where things are, right?
Exactly. Well, this can't be concentrated just for a small, fortunate few. Um, it's a tragedy that 3 billion people on planet Earth have hypertension, the number one risk factor for stroke and myocardial infarction. Half don't know it. And of those who know it, half hardly have it managed. And now we can, with your smartphone, be able to determine, or with a simple home monitoring device, be able to know whether or not you have blood pressure and get it properly managed. So there's an example of where a major risk factor for cognitive decline and for dementia and for stroke is so easy to detect and so cheap and inexpensive to treat, and yet it's not happening. So while I'm talking about what sounds like science fiction on the one hand and making that equitable, we're not even getting the simple things right. The fact that we spend $5 trillion a year in healthcare and 95 cents for every US dollar is spent on sick care or the treatment of chronic disease, that's a tragedy when 3% of that $5 trillion budget is spent on preventive care and public health. That's really where we need to shift things, because it's not sustainable, obviously, when you have, half of the people, half of young adults with at least one chronic disease, and 95% of people over the age of 65 with at least one chronic disease. We can do much better just with simple fundamentals.
Before we go into the tech part of research in brain health and what's available on the market for consumers and also on the professional side, there's just one thing I was really hoping that you would also clarify. So you mentioned that you might have amyloid buildup in your brain, but that doesn't necessarily mean that you are going to have cognitive issues. And that's one of the things that I thought were more interesting in the lecture from Mayo Clinic's Alzheimer's expert, Dr. Ronald Peterson at
Yes.
Atria Health, where he said that at age 85, the prevalence of biological Alzheimer's disease is 3 times higher than clinical dementia. So I just wanted to understand that a little bit more. So does that mean that basically the difference between what we can measure and what's clinically significant? Can you elaborate on that? Because that's where medicine is also going today. So focused on patient-reported outcomes, and the quality of life, instead of just focusing on what we can measure.
Yeah, Dr. Peterson is spot on. And it goes back to what I said about, a third of people over a third of older adults will have amyloid pathology in the brain. And so one would look at that and be tempted to say, well, they have Alzheimer's disease, and yet they're cognitively normal and may remain cognitively normal until they're 100 or older. And so why is that? Why is the same level of amyloid pathology, or even a lesser degree of amyloid pathology in the brain, leading to Alzheimer's disease in young people or younger adults, and more amyloid pathology in an older brain doesn't affect the individual? It's complicated, of course, but it's everything else that's happening in the brain and it's other risk factors. So if you had someone with amyloid pathology who was biologically optimized and their microvasculature was healthy and their gene expression profiles meant that there's not a lot of inflammation in the brain or systemically in the body, that individual may be protected, right? There are other genes being expressed that may mitigate the potential for that amyloid deposition to lead to continuous neurodegeneration that ultimately leads to the symptoms of memory loss and dementia. So it's complicated, but there's a number of factors. It's not just about a single protein that you can identify on a particular X-ray that determines what that individual is going to look like. I can't tell you. I saw a patient a few weeks ago who, we have gray matter or the cortex in the brain, and then we have white matter. And that person's white matter, if you looked at the MRI scan, you would say, oh my goodness, what is this person going to look like, right? You would think for sure this person was going to have vascular dementia. And yet this person was cognitively normal. And yet I can see another person with just a couple of spots or dots, and they have dementia. So why is that person so resilient in the face of what looks like really terrible white matter disease? So we see this all the time in medicine. And we as yet don't understand what accounts for that cognitive resilience. It is other comorbid and other conditions they have, or the lack thereof, but it's also, I think, something happening at the molecular level that's protecting that person from a protein that's being deposited in the brain.
I kind of find that a bit, I wouldn't say depressing, more fascinating, I guess, because it's, when we think that there's something that we can measure or know, and it turns out it's way more complex than that. So turning to technology, what do you see as most promising technologies, either in, supporting brain health, enhancing brain health? We've got discussions and development in the brain-computer interfaces space. On the consumer side, there's vagus nerve simulation. You mentioned the impact of GLP and blood glucose several times, and there's some people already measure their glucose and use continuous glucose monitoring, even though they don't have diabetes or other blood sugar related issues. So what do you see as, things that are not just a fashionable trend, but are already useful technologies for people to be aware of?
Yeah, great question. So I think I would divide it into technologies that allow today for the earlier detection of silent disease, if you will. So we have wearables and phone-based ECG monitors that can flag atrial fibrillation, for example, with very high diagnostic accuracy. I've seen it happen. And we know that just from this alone, I can determine whether or not I'm in atrial fibrillation. Atrial fibrillation is a major risk factor for not only stroke, but also for cognitive decline. So those wearables can detect that. I think from a modifiable risk factor standpoint, just to give an example, home blood pressure apps, telemonitoring, behavioral nudges, home blood pressure devices, even now your iPhone can tell you whether or not your blood pressure is elevated. I think in the very near future, we're going to have wearables that's going to actually continuously monitor your blood pressure. Because when you go into a doctor's office, or even when you're at home and you take your blood pressure while you're sitting and resting for 5 minutes with your feet on the floor, and your arms at heart level, your blood pressure may be fine. But what your blood pressure does over 24 hours, including what it does while you're sleeping, is another matter. So I think in the very near future, we're going to have continuous blood pressure monitors that are discreet, low profile, unobtrusive, and you're going to see over the course of a week, is your blood pressure, has it been mostly in a normal range? Um, Obviously crucial, but even today now we can tell with a flip of the phone or with a home blood pressure device what your blood pressure is. Type 2 diabetes, it seems like it's in fashion now to have a continuous glucose monitor on. And I think it's important if you knew, from a dietary standpoint, what is spiking your blood sugar, and if your blood sugar is mostly out of range while you're wearing that device, it would prompt an individual to see their physician, get other measures of insulin sensitivity and insulin resistance, and then have nutritional, exercise, sleep, and other potential therapies that would improve one's insulin sensitivity. Because insulin sensitivity, getting back to the brain for a moment, but also just metabolically and from a cardiovascular standpoint, is crucial to keeping a healthy heart and a healthy brain. I think continuous monitoring between visits, so remote patient monitoring, I think can reduce hospitalizations and emergency department visits in targeted populations. So I think virtual care is a way to remotely monitor and keep track of patients. So there are plenty digital devices that are available today that can tackle some of the most important risk factors, diabetes or the potential for diabetes, hypertension, that are here and available today and are only going to get much more sophisticated and accessible for people. Again, it comes down to, the importance of making these equitable to all people. One of the ways, we can't put a blood pressure device in everybody's home, but imagine, if you will, where 75% of the population around the globe has a smartphone. Imagine if a free app were available that would just, when you open your phone, takes your blood pressure. That's how I think we scale some of these technologies to make them available to people around the world, so that it's not just enjoyed by a few. Does that sort of answer your question?
Yes, yes. What everything that you mentioned does make me think is that yes, on the one hand, we can significantly improve secondary complications in existing patients through continuous monitoring and remote monitoring, but at the same time, healthcare, generally speaking, across the globe, is not getting less strained. There's, an increasing physician shortage, and also with these technologies, I think two things are happening. So one is that, we're trying to manage existing patients. There's a group of patients that want to be proactive and are already working on prevention. And then there's also the quality of technology that's available for consumers that are potentially creating unnecessary visits. So how much of that are you observing? I remember, especially when the first Apple Watch came out with AFib, there was huge discussions around clinicians being worried that patients are going to be running into their offices with no clinical reason, really, just because they were told by a consumer device that they might have a problem.
Yeah, and I don't think that has happened, actually. I do see a day, actually, to be honest, that where we're going to be able to aggregate and synthesize all of the wearable, nearable devices that are in our lives and that are passively collecting information, including, by the way, I'll give you an example. If I'm walking with my phone, the phone can now detect a fall risk and alert me and my clinician to the potential for fall risk. And that's just being passively collected. So when all of that is aggregated and synthesized and displayed in a dashboard that's consumer friendly and physician friendly with alert or detection thresholds. So if I'm carrying my phone with me and my heart rate is 120 when it normally is 60, that should alert me that something is wrong, and it should alert my clinician as well. So we don't want to drive people crazy and make them obsessive with data, nor do we want to burden already very busy and burdened clinicians. But that is the future, I think. And I also think that, we're going to have, biolaboratories in our toilets where, there will be information coming from our body fluids, if you will, that will be monitored, will be fed back through an app on your phone, and we'll have like a digital Waze for your health, right?
Mm,
Or a Google map for your health. I don't mean
yeah.
to be commercial here, but everybody knows what they are. And we'll have an AI digital coach on our phone telling us day to day, it's almost like having a FICO score for your health, that daily you'll get an update as to what your health is today, where the problems are, and exactly what the intervention should be today. Maybe
Mm,
dietary things you should stay away from. Maybe today you shouldn't have that glass of wine with dinner, et cetera, et cetera. So I do
yeah.
see a day coming where we'll have a, sort of a digital physician, if you were, a digital clinician in our phone that's aggregating and synthesizing all the passive and active digital technologies that we have in our lives. And I think they're going to become that much more prolific and available and accessible to people around the world, which
Yeah.
is great because even to this day, as a neurologist, you have to wait 6 months to get in to see me. That's just not acceptable, right? And when you finally
Mm-hmm.
do get in to see your clinician, they've got 15 or 20 minutes with you. So from a
Yeah.
capacity building standpoint, it's just not feasible um, to think that we're going to build enough clinical capacity with human beings, right, to manage
Yeah.
the health, to optimize your health. This is not going to be possible. So you will be
Yeah.
empowered. You will be empowered through digital technology to manage your health and know when it is time for you to seek the advice of a
Mm-hmm.
or a clinician.
Yeah, to a degree, we already see that mostly in the sleep management apps and smart rings that give you the readiness score and tell you, how well you slept, etc. But you mentioned capacity and the challenge of, having to wait for the answer for 6 months. So I think it's great for us to also open up the whole discussion around AI and chatbots. So there are solutions for clinicians such as open evidence, evidence hunt, up to date that have AI components to make it easier for clinicians to search for credible information. But there isn't such solutions for patients yet. So patients in many cases go to ChatGPT to look for answers, to look for explanations. And I'm wondering, in your clinical practice, how much of that are you already observing? Does that concern you, especially in psychiatry, for example? The research is coming out around the challenges of ChatGPT discussions or just generative AI discussions of not causing, but contributing to episodes of psychosis in vulnerable populations. So, where do you stand in the use of AI? There's obviously no one side or no one straight answer, but I'm wondering what you're already observing.
Yeah. As hyped as AI has been over the past several years, AI has been around for a long time, but it's especially in the zeitgeist right now. One can say that it's actually being underhyped as to the potential of what AI can do for an individual person's health and for healthcare and medicine in general. Um, I'll give you an example. So there is now what's called a AI diagnostic orchestrator that you can send off AI agents to scour a person's electronic health record, including all of their imaging and whatever pathology they might have. And imagine if they had actually had their genome sequenced, right? They can then go out into the medical literature and scour for both clinical trials that are ongoing for conditions that you have or conditions that you're at risk for, as well as go out in the literature and identify up-to-date, real-time, what the most important treatment interventions are, and generate an AI-generated report for you and for the doctor. That's going to completely revolutionize healthcare from a clinician standpoint, because when I go into a patient's room and evaluate that patient, imagine if you have a chatbot listening, meanwhile is scouring that patient's complete electronic health record over decades perhaps, analyzing all of the imaging they've ever had done, looking at all their laboratory data, and then I walk out of the room and it's giving me not only an AI-generated report, but it's telling me what the likely cause of that patient's symptoms are, what diagnostic evaluations I should run, and what I should be thinking about in terms of intervention. And that's based on up-to-date real, because I don't have time to read the 3,000 papers that have been published today or yesterday or the day before, right? I don't know. I can't possibly be up to date. No matter how much I know, no matter how focused I am on an individual area, I can't possibly be up to date. So imagine if that were the world for both doctors and for patients. So I'll go back to my comment about, all of a sudden your wearable detects that your heart rate is 120. Based on your entire medical history and based on your current metabolic profile, you're being told through your phone what the likely reason is for that elevated heart rate and what you should do about it. So I think this diagnostic orchestrator that's here, it's not yet being deployed widely in clinical practice, and it's not yet integrated into your phone or your mobile device, but it will be, I believe. And so the accuracy, the enhanced accuracy that doctors are going to be able to deliver to patients in terms of diagnoses and treatment, is going to be unprecedented. And I don't even think we can imagine how the transformation that's going to happen. I really think we've reached escape velocity now, as someone else has said. And I think the next 3 to 5 years in healthcare and in medicine are going to be utterly transformational.
Mm. Yeah, with several other implications as well in terms of, I think there's still a lot that we need to figure out in terms of, the energy consumption and the payment models for the use of AI.
Yeah.
But it's definitely true that it has had already significant positive impacts as well on the way that we search for answers and also look at new ways to approach health and healthy lifestyle. You spent, I'm glad you mentioned, how it's impossible to know everything because the knowledge is accelerating so far. This is why clinicians specialize for a very specific field. You specialized and still do a lot of research on headaches and migraines. And it's a bit, I guess, unfair that we just have 5 more minutes left to maybe talk about that a little bit. But I do wonder if you could in any way summarize what has been the biggest discoveries in the field so far. What would you say they are? What are you potentially optimistic in the field, especially since headaches can be in the general population. So I'm not talking about concussions or other reasons, but like in the general populations, headaches can mean nothing or they can mean very, very serious things. So what would you advise to people concerned about the severity of the headaches that they might have.
Yeah. Well, I could talk about this for obviously several hours because I spent the last 35 years focused on it. Not exclusively, but just certainly doing a lot of research and thinking about migraine and other headache disorders. Certainly, I think the needle has been moved over my time in this field in terms of the way people think about headaches and migraine. Almost 3 billion people have headaches. It's ubiquitous, right? It's hard to find a human being who's never had a headache. There are lots of things that can cause headache, and there are bad things, like there are sinister things that can cause headache, like aneurysms and brain tumors, right? But people, and this study's been done, if you take 100 people who walk into a doctor's office because of bad headaches, 90+% of them will have migraine, even though they think they might have tension or they might not be sleeping well, or it might be their diet. 90+% of them will have migraine, even though they might think it's something else like sinus. So migraine is by far and away the most common, what we call primary headache disorder in the world, over 1 billion people. There are plenty of other severe primary headache disorders, and by primary, I mean it's not due to another disease. And then you can have sort of other diseases that can cause headache. I think if someone's headache is unusually sudden, so anyone, even if you have migraine or even if you get headaches regularly, if someone's headache is what we call thunderclap, that's the headache that I worry about most. So when they have a sudden severe headache that goes from 0 to 10 in seconds or less than a minute, that can be a sign of something very, very serious, like a clot in the brain or a ruptured aneurysm, and that requires immediate medical attention. But a lot of people, because migraine is so severe and because cluster headache is so severe, that they think this is damaging their brain in some way, or something serious must be going on in my head, like a tumor, and it isn't. It isn't. But yet and so unfortunately, in medical training, when I was being trained, and that wasn't that long ago, it was like headaches were just like part of neuroses. It was anxiety. It was depression. It was muscle tension. Get a grip, pull up your boots and don't take yourself or things so seriously. And unfortunately, that was the way it was. And if you saw some of the things that have been published on headache over the past couple of centuries, even up, 35, 40 years ago, maybe it wouldn't shock you. But now, getting back to your question about advances, we understand now where in the brain a migraine headache originates, exactly where, and exactly the networks in the brain that are activated. And now we understand the molecular underpinnings. So one of the most recent advances was understanding that a certain protein, we talked about amyloid and Alzheimer's disease, and now we're talking about CGRP. It's letters that stand for a long calcitonin gene-related peptide. But CGRP is kind of the protein right now du jour for migraine. In fact, we now have, I think at last count, 9 different drugs, from nasal sprays to subcutaneous injections to oral tablets, that target that protein. And by the way, not a single clinical trial has failed when targeting that protein. So it's been a tremendous advance. And I think that's one of the reasons why people, and doctors in particular, are taking this disorder or disease much more seriously. Because, wow, we understand where in the brain it begins. We understand at a molecular level one of the proteins, and it's not just one, like Alzheimer's, but one of the proteins that is very important. And when we target that protein, we take migraine away, or we substantially reduce it in over half of the people. So I think now other proteins and peptides are being looked at and are being targeted and appear very promising. So when you understand at a molecular level, at a pathway level, a disease, with that level of fidelity, precision, and you can then target it with therapies, that that has conceptually changed people's viewpoint of migraine from being just a hysterical, neurotic um, condition. And, I'm telling you, this is 85% of the people I see with migraine are women. It's much
Mhm.
more common in women. And so, women have been marginalized with this condition for forever, for centuries. That's changed. So I think to get back to your question, what has changed? Conceptually, the way we look at migraine as a legitimate medical biological condition, that has changed. And the level of understanding at a molecular level that has led to designer drugs, if you will. Imagine in 2025, we actually had drugs that have been developed to treat migraine. Because in my career, for most of my career, I was using antidepressants and anti-seizure medications and blood pressure medications. It was like one of my patients said, it's the ugly stepchild of neurology. We take hand-me-downs from drugs that have been developed for other diseases and try to apply them to migraine. Now we have designer drugs that have specifically been designed to treat this condition. And that's a great thing for patients. And it's a great thing for doctors who treat patients with migraine and other headache disorders and can change their lives. It's the number
Mhm.
one most disabling medical condition in people under 50 on planet Earth.
Yeah.
And so when you
Well,
have that data, everybody now is taking this a little more seriously.
yeah, yeah, yeah. It's good to know that so much progress has been made. So there's even more optimism on the horizon. Dr. Dodick, thank you so much for the conversation today. We definitely will need to continue the discussion because, yeah, as you said yourself, this is a topic that definitely requires more attention than just 5 minutes. But I think that thunder clap warning is one of the most useful things I've heard in a long time about how to recognize a very serious headache from something that, can be managed more easily or is not dangerous. So thank you for that.
You're welcome. You're welcome. It's been a pleasure being with you. I look forward to speaking with you again.